Ever ask yourself what really goes on in therapy? Like, how does talking or doing specific exercises actually fix something as serious as crippling anxiety, severe depression, or paranoia? It really seems like magic sometimes, but it is actually a seriously structured scientific plan. Welcome back to the channel. Today, we are undertaking a deep dive into the psychotherapeutic treatments for the major and complex disorders outlined across almost the entire landscape of the DSM-5. This video is dedicated exclusively to common non-pharmacological psychological interventions. Our focus is on the powerful, evidence-based talking, behavioral, and cognitive techniques that help people change their core thoughts and habits. For every method, we'll break down what it is and how it works with a clear example. So let us get started. First, our treatments for anxiety and phobia-related disorders. Anxiety disorders are characterized by excessive fear and worry, and so psychotherapy targets the maladaptive thoughts and conditioned fear responses that drive them. Let's start with cognitive therapy, which is usually aimed for generalized anxiety disorder. CT, or generally known as CBT, is a form of psychotherapy based on the concept that emotional and behavioral problems stem, at least in part, from maladaptive or faulty ways of thinking and distorted attitudes towards oneself and others. So the core objective is cognitive restructuring. The therapist, acting as an active guide, helps clients become aware of their distorted patterns of thinking, such as catastrophizing or black and white thinking, and then helps them revise their perceptions by citing evidence to the contrary or eliciting it from the client's own history. For example, a client is worrying about a plane crash, and they might be guided then to review the hundreds, if not thousands, of safe flights they've taken and the millions of flights that have occurred daily, providing hard evidence to the contrary of their worries, in order to challenge the belief that disaster is imminent. Next is systematic desensitization, which is typically targeted for social phobia and related disorders. So this is a form of behavior therapy that uses the principle of counter-conditioning or reciprocal inhibition to basically gradually lessen the anxiety associated with a particular stimulus. So this goes over certain detailed stages. Specifically, it involves 3 distinct structured steps. The first, the client learns deep muscle relaxation techniques. Then, the client and the therapist create an anxiety hierarchy. This is a list of situations related to the fear, ordered from the weakest anxiety producer, for example, thinking about public speaking, through the strongest anxiety producer, such as giving an actual speech in public. The client then confronts each situation in imagination or in reality, starting with the least scary based on the anxiety hierarchy, while simultaneously practicing the relaxation techniques they learned earlier. Because relaxation and anxiety can't happen at the same time, counter-conditioning occurs, thereby having the fear response being gradually replaced with relaxation. So an example of this is a person with a fear of public speaking. They might start imagining standing up in an empty room while relaxed. Then after they have mastered that, they move up their anxiety hierarchy to imagining speaking to one friend in public, maybe, then a small group, and then until the fear is fully inhibited at each step. So gradually they go up the hierarchy until the fear is fully inhibited. Next is guided mastery, which is typically aimed towards specific phobias such as heights or animals. So this is a quick and effective behavior therapy designed to restore reality testing. This is done by actively disconfirming phobic beliefs using hands-on assistance. So this treatment enables people to eliminate severe phobic behavior by increasing their sense of self-efficacy, or their belief in their one's own ability. The therapist uses participant modeling, meaning they first model the safe behavior, such as touching the phobic object, and then guiding the client to perform the feared behavior as well, using constant support. And through this, it breaks the fear down into small, achievable steps. So, for example, a therapist uses coaching and modeling to help a client with a height phobia, gradually letting them stand closer and closer to a tall railing in a building, eventually encouraging them through multiple sessions to then lean into it to prove that it's safe. So similar to the previous therapeutic technique, it's a step-by-step process. Finally, we have applied relaxation. So this is a more general type of technique. in which clients are taught in a similar stepwise fashion to relax more and more rapidly over a series of sessions. So the goal of this technique is to train the client to achieve a relaxed state in as little as 20 to 30 seconds, usually in situations where panic, phobias, or other symptoms typically occur. So an example of this would be a client with a panic disorder who practices relaxing their body rapidly upon seeing their panic trigger, such as stepping into a crowded elevator, thereby inhibiting the anxiety response. Now let's move forward into therapeutic techniques for mood disorders. This covers both unipolar and bipolar disorders. So, mood disorders range from persistent lows, such as major depressive disorder, to extreme highs and lows, such as in bipolar disorder. So psychotherapy in this group provides essential structure and coping skills. The first of which is problem-solving therapy. This is typically aimed towards depression-related disorders. So this is an evidence-based cognitive behavioral intervention that improves an individual's ability to cope with stressful life experiences by enhancing their problem-solving skills. So PSD helps clients acquire 5 core skills: defining the problem, generating solutions, decision-making, which is, in other terms, evaluating consequences, and implementing or evaluating the chosen solution that they have made. So it targets the belief that life's problems are insurmountable. Basically, in essence, it is teaching the client that their problems can be overcome. So for example, a depressed client is overwhelmed by responsibilities, and so they are guided to break a large goal, for example, cleaning the house, into small, manageable steps, such as clean 1 shelf, wash 3 dishes, thereby restoring a sense of agency within the client. The next technique is interpersonal and social rhythm therapy. This is typically aimed for those with bipolar-related disorders. So this is a disorder-specific psychotherapy that focuses on helping people with bipolar disorder regulate their daily routines and social interactions. So the core idea in this technique is that disruptions to social rhythms, such as sleep-wake cycles or social schedules, can trigger mood episodes such as mania or depression. So basing on this idea, the therapist helps the client identify and maintain consistent daily routines to stabilize their internal biological clock. So clients use this technique to track when they go to bed, wake up, and have social contact in order to establish a consistent social rhythm or social calendar or schedule. So for example, a client in recovery from a manic episode who often stays up late socializing is helped by establishing a strict, non-negotiable bedtime and wake time, as it has been noticed that their sleep loss can trigger mood episodes. Next, let's move forward to family-focused therapy, which similarly to the previous technique is also typically aimed towards bipolar-related disorders. So this is a psychoeducational and behavioral intervention that includes all family members to improve the course of bipolar disorder. Speaking broadly, this doesn't have to be limited to bipolar disorder alone. This can also be expanded to other related disorders, as this is more of a psychoeducational technique. So FFT aims to improve communication, enhance conflict management, and teach the family to recognize the signs of an impending episode. It focuses on addressing the emotional environment that can contribute to the relapse, if any, and reducing the expressed emotion that could contribute to that relapse, such as criticism or hostility. So, as an example, family members learn to use I feel statements instead of accusatory language, such as you always. An example would be, I feel hurt when you raise your voice at me when speaking to the client when they are irritable due to a depressive episode, as opposed to a you always statement such as, you always are so mad at me. This is done to de-escalate potential conflicts that could otherwise trigger a mood swing in the patient. So now let's move forward to some techniques or therapies that cover trauma and obsession-related distress disorders. So these disorders are characterized by intense, intrusive mental activity and structured avoidance behaviors. So the first therapy that we'll go over is exposure and response prevention, or ERP. This is very commonly aimed towards obsessive-compulsive disorder. This is an intensive form of behavior therapy involving exposure to situations that trigger obsessions, followed by abstinence from the compulsive ritual. The critical component here is response prevention. Upon exposure to something that triggers their obsession, the client agrees to prevent the compulsive ritual, also known as the response, for a prolonged period, thereby forcing that client to sit with the anxiety until it naturally subsides, a process called habituation. which is rooted in conditioning. So the goal is to break the association between the obsession, the ritual, and the temporary relief. So for example, a client with contamination OCD is asked to intentionally touch a trash can lid and then refrain from washing their hands for several hours, proving to their brain by experience that the anxiety naturally fades and no harm results. Next is prolonged exposure, which is typically targeted towards PTSD and related disorders. So this is a specific form of CBT where clients repeatedly confront memories, feelings, and situations that they have been avoiding since the trauma. So P involves two main types of exposure. First is imaginal exposure, where the client verbally relives and describes the traumatic event in the present tense, often recorded for homework. And the second, in vivo exposure. This is where the client gradually confronts real-world situations, places, or people that they have been avoiding due to trauma-related fear. So the goal in this one is emotional processing and reducing avoidance. So for example, a veteran who avoids crowded places due to a traumatic memory might be then guided to visit a moderately crowded mall, thereby utilizing or undergoing rather in vivo exposure. And a session might involve them repeatedly narrating the event of the trauma until the distress rating that they report on significantly decreases. So now let's move on to some therapies for schizophrenia spectrum and psychosis-related disorders. So psychotherapy for these disorders focuses on improving function, reducing the stress from symptoms, and enhancing community integration. So the first of which is cognitive behavioral therapy for psychosis, or CBT-P with a small p. So this is similar to what we've discussed before. This is an evidence-based treatment approach shown to improve symptoms and functioning in patients with psychotic disorders like schizophrenia and schizoaffective disorder. And also, as you've noticed, CBT is very versatile. And if I'm not mistaken, this is one of the most commonly used therapies for most disorders due to its versatility. So CBTP is a collaborative process that focuses on the appraisal or interpretation and response to psychotic experiences, such as hallucinations and delusions, rather than challenging the existence of the symptom itself. Essentially, the goal is to reduce the distress and disability caused by these experiences. It helps clients reality test and develop coping skills. So for example, a client with auditory hallucination, who typically interprets the voices as proof that they are evil, is guided to reappraise or reinterpret those voices as a symptom of their illness, rather than as proof that they are evil. And then they are taught coping skills like distraction or engaging in an activity to manage the distress. Next, let's move forward to assertive community treatment. This is a more general type of technique that can be broadly applied. So in this type of technique, a service delivery system that uses a mobile multidisciplinary team, such as a team consisting of a social worker and a nurse and so on, are present to provide a range of support services. So ACT is an intensive wraparound service where the team establishes a close relationship with the individual and delivers treatment, rehabilitation, and support services at home and in the community, whether it would be at work or in the neighborhood. So this high-contact approach reduces hospitalizations and increases functional independence. So for example, an ACT team member might accompany a client to a doctor's appointment, help them with budgeting, or practice social skills for an upcoming job interview, thereby providing real-time support in the client's actual environment. Finally, we have social learning or token economy, and this is typically aimed towards those who are suffering from schizophrenia or related disorders. So this is a behavioral program, often in an institutional setting, where desired behavior is reinforced by offering tokens. So the tokens act as secondary reinforcers that can be exchanged for desired backup reinforcers, like special foods, television time, or passes. It almost functions like money in a sense. So it aims to shape and maintain basic adaptive behaviors like hygiene, self-care, and group participation. So for example, a patient earns 1 token for making their bed and 2 tokens for attending a therapy group session. And then they collect these tokens and can trade them in for something that they would like, such as a movie ticket or a special meal. Now let's move forward to therapies that cover eating, somatic, personality, and sexual health disorders. This category is quite a mix, but I tried my best to just cover what seem to be the most common ones among these categories. So basically, this group, due to their diversity, covers mind-body connection, self-image, acceptance, and correlation dynamics as the primary therapeutic targets. So let's first start with family-based treatment, or alternatively called the Maudsley Method. This is typically aimed towards those who are suffering from anorexia nervosa, notably among adolescents. So this is a specialized, intensive, time-limited treatment that includes all family members in the recovery process. So, specifically focusing on the Maudsley Method here, this approach empowers parents to take an active and primary role in the nutritional rehabilitation of their child. The treatment has 3 distinct phases, the first of which is weight restoration. Parents are tasked with actively and assertively ensuring their child eats to achieve a healthy weight. The therapist acts as a coach and a resource. The second stage is returning control to the adolescent. Once weight is restored, control over eating is gradually returned to the adolescent in an age-appropriate manner. Finally, the last stage, establishing healthy adolescent identity. The focus shifts from food to normal psychosocial development and addressing underlying family issues that may have contributed to the development of this disorder. Now let's move forward to interpersonal psychotherapy. This is typically aimed toward bulimia nervosa and related disorders. So this is a time-limited therapy based on the theory that relations with others are the primary influence on human behavior, linking interpersonal stress to maladaptive behaviors. So IPT helps the client clarify their interactions with significant others, focusing on 4 problem areas: grief, role disputes, role transitions, or interpersonal deficits. By resolving the underlying interpersonal problem area, the core concept is that the eating disorder symptoms will often lessen, as the client no longer needs them as a coping mechanism. For example, a client who binges and purges to cope with the stress of a recent role change, such as becoming a new parent, would focus in IPT on developing healthy coping skills for the demands of the new roles and strengthening their relational support system. By doing this, their binging and purging behaviors will then lessen over time. Now let's move forward with sexual counseling, such as the PLI-SSIT model. This is typically aimed towards sexual dysfunctions and related disorders. So this is a structured sexual education and counseling based on established theories and models to improve sexual function and reduce distress. So going deeper by focusing on the PLI-SSIT or PLICIT model, this is a progressive approach to sexual counseling, and it goes over its stages through its acronym. So first is permission, giving the client permission to feel comfortable about their sexuality. Next, limited information, providing specific, correct information about their problem. Next, for the 2 S's, specific suggestions. This involves providing direct behavioral suggestions, such as utilizing a lubricant or increasing non-demanding physical touch. Then finally, intensive therapy. This, however, is only used for complex issues, requiring specialized long-term treatment. So for example, a couple experiencing low female arousal, the counselor provides specific suggestions like engaging in non-goal-oriented touching or using sexual toys or tools to increase blood flow and arousal. Finally, in this category, we have dialectical behavior therapy, and this is specifically aimed towards addressing the core features of borderline personality disorder. So this is a comprehensive evidence-based treatment that targets the core features such as pervasive emotional instability, identity disturbance, self-harm, and chaotic relationships, which are commonly seen in BPD. This therapy is unique because it combines individual therapy, group skills training, and phone coaching. It operates on the dialectical principle of balancing acceptance, specifically towards one's reality and oneself, and change as well. So the therapy teaches 4 core skill modules. The first of which is mindfulness, which is staying present and non-judgmental. The next is distress tolerance. This practices coping with crisis without making things worse. The third stage is emotional regulation. This is understanding, naming, and changing intense emotions. Finally, the last stage is interpersonal effectiveness. This focuses on getting needs met while maintaining self-respect in relationships. For example, when overwhelmed by a crisis, a client uses a distress tolerance skill like TIP, that's TIPP, which refers to temperature change, intense exercise, paced breathing, and paired muscle relaxation to quickly change their physiological state and get through the intense emotional moment without self-harm or destructive behavior. Now let's move forward to our final category, therapies that cover substance abuse and addiction-related behavior. So addiction treatments focus on skills training, immediate reinforcement, and motivational support to sustain abstinence. The first therapy is community reinforcement approach. So this is a comprehensive behavioral approach based on the belief that the individual's environment can play a powerful role in deterring substance use by reinforcing alternate positive behaviors. A form of this is CRAFT or CRAFT, which is short for the Community Reinforcement and Family Training Model, which is a specialized version used to engage treatment-resistant individuals by working directly with their family members, who are also referred to as concerned significant others. Family members learn communication skills and how to reinforce sobriety-related behaviors, while allowing natural consequences to follow substance abuse, thus encouraging the user to seek treatment. For example, under the CRAFT model, a parent is taught to positively reinforce their child for attending a recovery meeting, doing so by offering praise or spending time together, but they are taught to stop nagging or offering financial support immediately after a relapse. The next therapy is contingency management. This is a broad group of behavioral interventions that provide or withhold rewards and negative consequences quickly in response to at least one measurable behavior, such as a toxicology screen or drug test. CM is highly effective, especially for cocaine and methamphetamine users. It uses a concrete system of positive reinforcement, such as vouchers or prizes, that the client earns by providing drug-negative urine samples. The magnitude of the reward often increases with the number of consecutive negative results. This is similar to the token economy, as seen in this example. A client earns a voucher every time they provide a clean urine test. The voucher can be exchanged for retail goods or services that support a sober lifestyle. And finally, our last therapy is motivational enhancement therapy. This is a brief counseling approach, adapted from motivational interviewing, designed to help clients resolve ambivalence about engaging in treatment and changing their substance use. MET is non-confrontational. The therapist uses empathic listening and reflection to help the client understand the reasons for and against change, thereby building the client's intrinsic motivation. It is often used as a preliminary step to prepare clients for more skills-intensive therapies, such as CBT. For example, the therapist asks the client to weigh the pros and cons of using a substance versus staying sober, also known as a decisional balance exercise, in order to help the client articulate the discrepancy between their values and their behavior. And that is the end of the video. We have taken a journey through some of the common non-pharmacological interventions in modern psychology. If you found this breakdown valuable, please hit that like button, subscribe for more in-depth mental health content, and let us know in the comments what therapeutic model you found the most fascinating. Thanks again, and bye-bye!